What's up, everyone? It's Miles here from bootcamp.com, and today in pulmonology, we're going to be going over pulmonary fibrosis. So first, we're going to talk about idiopathic pulmonary fibrosis, or IPF. And what's happening in this disease is we're getting irreversible fibrotic deposition in the lungs, and the etiology is not completely understood, hence why it's called idiopathic pulmonary fibrosis. And the fibrotic deposition in the lungs usually happens over a long period of time. So there's going to be a slow onset. So this condition doesn't really occur overnight. It requires months to years to develop. So the main symptom of idiopathic pulmonary fibrosis is going to be dyspnea or trouble breathing. However, we can also see a non-productive cough, fatigue, and recall that in pulmonary fibrosis, we can also hear crackles. So the diagnosis of IPF can be made on chest x-ray or CT, and on chest x-ray, what we're going to see is bilateral, diffuse, reticulonodular opacities, and this represents the fibrosis in the lungs. And reticulonodular is just a description of a net-like pattern of nodular fibrosis. So if we just take a look at this chest x-ray here, we can see this bilateral diffuse pattern of reticulonodular opacities here, which is characteristic of idiopathic pulmonary fibrosis. And furthermore, on CT, we can see a honeycomb appearance to the lungs, and this is due to the dilated airways that we see in pulmonary fibrosis. So if we just take a look at this CT scan right here, we can see all of these dilated airways here, which is giving the lungs the honeycomb appearance, which is characteristic of pulmonary fibrosis. Okay, so the pathogenesis of idiopathic pulmonary fibrosis is not completely understood, but it's thought to involve a repetitive lung injury followed by disorganized repair. So when we have repetitive lung micro-injuries, like for instance from acid reflux or smoking, what's going to happen is we're going to have the injury of type 1 pneumocytes, and we're going to have the formation of an abnormal basement membrane. Now recall, when the type 1 pneumocytes are injured, it's the type 2 pneumocytes that can regenerate and give rise to new type 1 pneumocytes. So what's going to happen is the type 2 pneumocytes are going to attempt to regenerate the type 1 pneumocytes. However, it's thought that in order for the type 2 pneumocytes to properly differentiate into type 1 pneumocytes, we need to have a normal basement membrane for normal signaling. However, with repetitive lung microinjury, we're going to have an abnormal basement membrane. And so when the type 2 pneumocytes undergo hyperplasia, they're going to have failed differentiation into type 1 pneumocytes. And so because the type 2 pneumocytes are not regenerating the type 1 pneumocytes properly, we're going to have impaired reepithelialization of the alveoli. And this impaired reepithelialization is going to signal local fibroblasts to undergo focal proliferation and start to lay down collagen, which is the fibrotic deposition that we see in idiopathic pulmonary fibrosis. So just to summarize, using this diagram here, we have the type 1 pneumocyte, which is making up the wall of the alveoli, and we have the type 2 pneumocyte right here. And when the alveoli is injured, so when injured, the type 2 pneumocyte will give rise to new type 1 pneumocytes. However, if the type 2 pneumocytes fail to differentiate into type 1 pneumocytes because there's an abnormal basement membrane present due to that repetitive lung microinjury, then we're going to get an impaired repair response. And it's here that the fibroblasts get activated to start laying down collagen, which is going to result in the pulmonary fibrosis. Okay, so now we're going to finish up by talking about drug and radiation-induced fibrosis. So the idea here is that certain chemicals and radiation can cause damage to the lungs, and this damage is going to result in scarring and fibrosis of the lungs. And 4 drugs that commonly come up in boards questions as drugs that cause pulmonary fibrosis are bleomycin, amiodarone, methotrexate, and busulfan. So I would note these drugs down as causes of pulmonary fibrosis. And lastly, as we mentioned, radiation can also damage the lungs. Within about 12 weeks of the radiation, we're going to see inflammation of the lungs called pneumonitis. However, after about 6 to 12 months after the radiation, we can start to see scarring of the lungs and pulmonary fibrosis. All right, and that's all we got for our video on pulmonary fibrosis.